We welcome you, ma'am, for today's session and request you to start the session.
Thank you, sir. Thank you so much for the introduction. A warm welcome to all of you. So today's topic.
Participants are requested to kindly bear with us. Ma'am will join us again shortly. We're requesting all participants to kindly bear with us. Ma'am is joining in 2 minutes. Praveen sir, ma'am has joined.
Yeah, mic is open now.
Okay. Right.
Hello, can you hear me
Yes,
now?
yes, ma'am. We can hear you. The screen is
Some
visible.
technical error. I don't know, something I clicked.
No problem.
Right. So when it comes to talking about the comorbidities in CLHIV, I was just asking the participants what are all the problems normal children have, and all the more with our HIV children. So what problems do they face? Anybody can unmute. Do we have the facility that they unmute and answer?
Yes, ma'am. They can unmute or they can even type in the chat box.
Yeah, so they can continue chatting. So in the this thing, and then we can go ahead. So usually they may have problems like anemia. They may have problems of respiratory system. They may have problems of the CNS system. Is it not so? So let us see what all is there for today's session. Okay. So here, whenever the children present to us with HIV, they will have lot of comorbidities and all the symptoms of many systems at a time they may present. They may not be just asymptomatic, come like that and we diagnose HIV. Okay. So they will have clinical manifestation, and this all depend upon the age and the severity of the immunodeficiency. Okay, and at a time when they are presenting, they may have one or more system that is involved, right? So and we have to therefore clinically stage the disease, and then as well we have to start the ART therapy. So the system which is involved will have a direct influence on the health status, and it will indirectly indicate the mortality also, and it will give us a clue also whether the patient was adherent on the ART, because we see oftenly that the adherence to the ART drugs in children is really problematic, and that is the cause for sometimes they go into SASP because of the drug resistance. So all the systems may be involved directly due to the HIV virus or sometimes because of the OIs. Okay. So with this introduction, I want to tell you what are all the different problems of malnutrition, of anemia, of liver diseases, respiratory diseases, neurological problems. So let us go further in this session. So what are the common comorbidities they will have? See, infection when they may have the infection. Tuberculosis, as we know, almost 50% of our HIV children do have tuberculosis. And when they are immunosuppressed, the bacterial infections are very, very commoner. Viral infections are common. Fungal infections are very common. And they may have septicemia, disseminated septicemia and DIC they may land up with. Nutrition paranga emautundi, what is happening when there is a problem with the nutrition, then because of the drugs on ART drugs also, that may cause nausea, vomiting, and the children tend not to eat much, and they may land up with multiple vitamin deficiency. Then they may have wasting, they may have stunting, they may present as oral candidiasis. When we see them as having oral candidiasis, then they may have diarrhea, they have oral ulcers, and this diarrhea continues persistent as persistent diarrhea. Okay, because of the drugs, they may have hepatotoxicity, they may have infection per se because of hepatitis B, C, or A, and other organisms also. Child, when we see, sometimes will have anemia and thrombocytopenia. This can be because of the drugs also, or because of the HIV disease also. When you see the children presenting to us with developmental delay and microcephaly, child has attained some milestones but starts to regress, or child may present with directly meningitis as a presentation. Okay. So we need to know when our children are coming, how, when in every visit, we need to monitor about their development, whether they are growing normally or not, whether at the time the child should walk or sit or play or run, or the language which they are speaking, is it appropriate for the age or not, or there is a delay, that we need to see. Okay. The child may present to us with persistent pneumonia, bronchitis, sinusitis, CSOM. So they may have ear discharge, and they may have something called as lymphoid interstitial pneumonitis. Your pre-test also had the question, bronchitis is which stage? So we will know what is the stage now. If you've answered rightly, you should pat to yourself that yes, you know. Then what are the skin and soft tissue infections which the child can have? They may have bacterial infection, fungal infections in the form of tinea corporis, and bacterial infection like furunculosis, pustules and boils, and cellulitis. They may have nutritional dermatosis. Nutritional dermatosis, mainly we have zinc deficiency. Okay, they may land up with infections of scabies, molluscum, herpes, and they may have pruritic papular eruptions. They can have skin rashes, all because of the ART drugs also. So most common is what? Malnutrition. This is most common thing which we see in the infants and young children, and they will present with wasting. And sometimes older children who are there, they may have intermediate disease, and they may progress very rapidly, and they continue with having this stunting. Okay. Malnutrition becomes a very important cause of mortality in children. Okay. More so in our part of the country. Our part of the subcontinent rather. So sometimes what happens is not all malnourished children we will admit. So when the children is having a severe malnutrition, that is we call as SAM, those children we will hospitalize and treat. But ma'am, that is moderately malnourished children, we can manage outpatient, we can tell them, we can teach them, we can counsel them, and then that can be managed on the outpatient basis also. So how do we know nutritional status of the child from 0 to 59 months? What we will do, normally what we do, we see the weight, we see the height, and we plot on the graphs, okay? So when then we can classify, yes, this child is a normal child if his weight and height is normal for that age. If it is less, then we are calling underweight. When are we going to call the wasting and stunting? Is height is not matching with the age or weight is not matching with the age, okay na? So when we, so this is the score. See what is happening here, we are saying it is called as a standard deviation score. So what is normal? Normal is below 1 standard deviation, okay? So child's weight is appropriate for the age. Say I tell you the child is 1 year old, okay? So weight of the child is 10 kgs, that is appropriate for that age, okay? So weight is also normal. Height, length of the child, say the child is around 70 centimeters, the length is also normal. So weight for age, weight for height is normal, so child is normal, okay na? And that is below 1 standard deviation. Below 2 standard deviation we call it moderate underweight. Here what is happening, the child's height for age is less and child's weight for age is also less. When it comes to below 3 standard, it's a red zone. You're understanding, this is red zone means it is severely underweight and severely stunted, okay? So I'll take the example, same example of a child 1 year old. When we say it is normal, the weight was 10 kg, height was 70 centimeters. Suppose if it is moderate nourishment, the child's weight is around 6 kg, 6 to 7 kgs, and the height is around 50 centimeters. Below third centile means the weight is around 4-5 kgs, and the length of the baby is around 40 to 50 centimeters. You understand? So normally the child should have been 70 centimeters or 10 kgs, as now only 5 kgs, or the length is around 50 to 70 centimeters. So 50 to 60 centimeters, then definitely this child is severely stunted. Right? So what we have to do is we have to, whenever we are seeing the child, whenever the child is visiting our center, we have to see the weight, we have to check the anthropometry, we have to see clinically also how the child is growing, okay? So what all we do, weight, height and mid-arm circumference also we will see. So severe malnutrition, when we will say, when mid-arm circumference is less than 11.5 centimeters, okay? And we see that the weight is less. What else we can see? We have to see for the edema on both limbs. See, the children, if they have edema on both the limbs, we will call it as kwashiorkor, or severe wasting, visible severe wasting. And చూస్తే మాత్రం ఆ baggy pants laga there will be folds on the buttocks, and the cheeks are all hollow, no fat is visible, child looks very wasted. That is a severe malnutrition. But what is moderate malnutrition? Where we saw, no, the height and weight is between second to -2 to -3 standard deviation here, and here the mid-arm circumference is between 11.5 to 12.5 centimeters, okay na? Below 11.5 we will call it as severe malnutrition, but between 11.5 to 12.5 we will call it as a moderate malnutrition. And here in these children there will be no edema or severe wasting. When it is edema and severe wasting with less than 11.5 mid-arm circumference, then we call it as severe malnutrition. When it is between 11.5 to 12.5 with no edema and no wasting, we will call it as moderate malnutrition. Are you understanding there? All of you, are you getting what I'm saying? This is very important because in your centers you have to see it. Because if the child is severely malnourished, you will admit and give fluids, and therapeutic feeding should be done. Moderate malnutrition, you can give counseling, you can tell about the diet, and then you can treat OP basis only. These are the things, these are the charts, WHO charts for height and weight. So you have to see correspondingly what is the height and what is the weight of the child. And these are the standard deviations. You see, -1 standard deviation, -2 standard deviation. So where your child is, they falling. Okay. You're understanding here? Is it clear till here? So what you have to do, refer to the chart for weight for height and length of the child. You have to see and see for the standard deviation score where you are lying. So the child may be lying less than 2 standard deviation, less than 1 standard deviation. Be in between, if suppose the child is between these scores of -2 standard deviation, that is coming less than 1 standard deviation. Okay. Between 1 and 2 unte -1. Okay. Now, how to measure the upper arm circumference? Why is it significant? Upper arm ante, it has to be between the bone. Your shoulder bone is that is from there till the olecranon. Okay, na? To the tip of the shoulder, you see in the figure, you are seeing how it is to be measured. Locate the tip of the shoulder and tip of the elbow. And in between, you have to measure and put the tape. Okay. And then you have to insert the tape. Would have seen this tape, na? See, this is a tape. You have a window. So you rotate it and put through the window the other end. All right. And what is the centimeters? It will come in that window only. So check that number and there it is. So when it is red, when it is less than 11.5, when it is more than 12.5, it is green. But yellow is between 11.5 to 12.4 centimeters. Okay. This is okay. You have seen the child's weight and height. You have plotted on the graph. Then you have seen the mid upper arm circumference. Then what you will do? You will see the look of the child. See, the child is literally bones. You are seeing the ribs. You are seeing the upper arm skin loose. Skin is very, very loose. Thighs look very loose. Okay. So this is the front and the back will see the child's baggy pant-like feels. You see over the buttocks, the folds are there. And you see the spine, you will see all the bones. So this is called as a severe wasting. So visible severe wasting is equal to severe acute malnutrition. Okay. Edema in strand starts from the dependent parts where it will be seen mostly on the feet. Okay. Once it is more, it will extend to the legs also, and the child may have anasarca. When you will have this anasarca, when there is a severe hypoproteinemia, and if you press on that and press for 10 seconds, that is 1001, 1003, 1 and 1002 and 1003 and leave, you will see a pit or a dent. That is called as a pitting edema. Okay, bilateral limbs you should see. Okay. You're seeing in the figure, you could appreciate this. So what you should do, even when it is a moderate malnutrition, what we have to do, we have to counsel the mother how. First, you should extract the history. Ask her what all you are feeding, how she is feeding, is it an active feeding, so that the mother is interacting with the child, feeding herself, talking to the child, and seeing how she's feeding the child. Find out any problems, local problems are there for the child. Say the child has a cleft lip, cleft palate, child has some difficulty swallowing. In such conditions, we have to refer to the higher center. So in the history, you should find out how she is feeding, what she is feeding. She may say, I'm giving a glass full of milk. No, but you should see how much she is diluting it. If she is saying a katori full of rice she is giving, you would see the density. Katori of food, no. If the child is eating only one bowl of rice or a bowl of some kanji, you should see whether she is putting it some ghee along with it, or the katori was cleaned properly or not. So you need to talk about washing the hands of the mother and the baby, and then when she is feeding, she should wash the vessels also properly. And whatever the small amount the child is in, try to make it more energy dense. How can you make the food energy dense? You have to put ghee or oil, and you need to food diversity and ante. See different types of food, seasonal fruits she should can good give. She can match the fruits like mango or something like that's in the season, and put it in the milk, and she can give mashed banana. She can give more calorie dense food. She can give like payasam or rice porridge where she can add on ghee. Like this she should do. You need to tell them. But the child is having some other heart disease or cleft palate is there, some other medical problems, infections, which you think it cannot be managed in our center, kindly refer such patients to the higher center. But if there are no medical conditions, you need to teach the mother about how frequently she should feed, how she should make the child sit and eat, appropriate for the age. She should tell the consistency also. If the child is only 6 to 7 months, the consistency should be semi-solid where the child can just swallow. So it should be more liquid. If that has been told, you should check on the consistency because sometimes they may dilute too much. So what we have to give is see that the condition, the food which is given is energy dense, hygienic, appropriate for our age, the density of the food and the consistency. Like the consistency should not be very liquidy, whether it goes out of the spoon. So she has diluted too much, not like that. So semi-solid consistency pertaining to that age, we need to teach her and counsel her. Okay. So in moderate malnutrition, we can always tell them and counsel them, and that treatment can be done on OP basis and can be discharged. But in children, where we define the SAM, what was the definition? Where the mid-arm circumference was less than 11.5, where there was edema, visible wasting could have been there. So in such conditions, we need to admit this child. Okay, so SAM management, where we have seen medical complication is there, you will admit in the facility. What we can do is we have to give F75. This F75 is 75 kilocalories will be given to the children. This is usually milk based. So in the milk, you can add on the sugar and make it to in such a way that the calories which it gives is 75 kilocalories. F100 is cereal based. You can mix some puff fries and all those things, or ready to use formula can be used, and that can be given in the center where the child is admitted. In such centers, what should happen is, if you are giving one bowl of say milk and puffed rice, powdered puffed rice mixed with some oil and sugar, that whole bowl the child may not eat. At least 70% the child has finished. 3/4 of the bowl the child has finished means it's okay. The child is passed the appetite test. So good appetite is there for this child. Okay, now, so this and edema has come down, child starts to eat, child starts to gain weight and loses that edema. The child got admitted with edema, no? Bilateral edema was there. This edema goes away, the infection is getting controlled, the child starts to eat, then we can discharge the child. Transition criteria from facility based to again we can shift back to the community center. In community center, what we are doing, where the child has a good appetite, child has no medical problems, we will manage in the community. Okay, so in front of us we can make them eat the F75 and F100. Hospital admission lo em chestaru, we have seen that there are medical complications. What are that medical complication? Child may have fever, child may have vomiting, child may have fast breathing. Diarrhea and dehydration is the most common thing. The skin is already loose and you will not be able to find out the severity of the dehydration. So you should see whether the tears are there or not, tongue is dry or not. That can be an indirect indication to see severe dehydration, because here the skin already is loose. You are getting my point. And the skin is already loose, you will not be able to assess how much is the dehydration. We have to assess severe dehydration means you pinch the skin and the skin goes immediately, there is no dehydration. Mildly it goes is moderate dehydration. Severe dehydration, it goes very slowly. But in your SAM children, already the child's skin is very, very loose. It will go otherwise also normally low, slowly. So that cannot make the child to have severe dehydration. Okay. Indirect evidence, what you will see is, you will see for the tears, you can see for the urine output, you can see the tongue, if it is dry or not. Okay. So that is the way you will assess the diarrhea and dehydration in children. Anemia, you have to see, you can see whether the child is bleeding or child has some petechial spots, purpura is there. And as we discussed just now, the systemic infections like the child can have pneumonia, bronchiectasis, the child can have diarrhea, or neurological infections like meningitis can be there. But most common thing is child may have hypothermia because child doesn't have fat only. So child lands up with hypothermia. Okay. And these are very, very emergency sign. You have to treat immediately. You have to admit the child and start to treat these babies. So first we will see anemia. What do we mean by anemia? Anybody? Unmute and answer.
Low hemoglobin level.
Low hemoglobin, exactly, very good. So the RBCs are very less and it is not able to maintain the body's physiology. Okay, na? So whatever need is there for the body, that is not been maintained. So the hemoglobin is low. So when can we call it a severe anemia? Adi oka question unde kada meeku pre-test lo. Anybody can answer?
Less than 8 is severe anemia.
Very good. Very good. Let us see. Yes, so good. So here anemia is a condition where the RBCs are insufficient to match the physiological needs of the body. And when do we call it as anemia? When it is less than 11 grams in child between 6 months to 59 months. Okay, so 0 to 5, 6 months to 5 years, 11 less than 11 is the normal. It is anemia, but severe anemia is less than 7. Less than 8 is between 5 years to 12 years. Okay. Anytime hemoglobin between 11.5, less than 11.5 or 11 is also okay, but less than 12 grams in 12 years old children and severe anemia. When we see in children, we will call as less than 8. Okay, severe anemia is less than 8. But up to 5 years, it is less than 7 also. Okay, na? So, very common we see anemia in children, and one of the most common causes can be because of the worm infestation in routine children. But in our HIV children, what happens is they are on the ART drugs. And which drug can cause anemia?
Zidovudin.
Yes, very good. So zidovudin, yes. So anemia can also be there because of the other concurrent other nutritional deficiencies, also chronic diseases as we saw. So that also can make the child more anemic. Okay. So what all we should see? How do we know anemia is there? What can be the history we can ask them?
Weakness, generalized weakness.
Yes, very good. Anything
breathlessness, pallor.
Where do we see for pallor?
The palms, the nails.
Good, very good.
The cheeks.
Eyes you can see.
But the
palpebral conjunctiva you should see.
Yes,
but as per IMNCI guidelines, where do we see? In the palms, as you rightly said in the first answer.
Yes.
Right. So here in when you are seeing this anemia, when you are taking the history, just a second. So when you are seeing the anemia, you will, as she rightly said, so easy fatigue liability should be there. The child will be having dizziness, pallor. Child will be having breathlessness. Child can have headache, and sometimes there might be blood losses also. Like there can be diarrhea, dysentery, where the child can lose the blood, kada, or there can be child might be having hemolytic anemias. Okay, where the RBC's life is only less and that is going on breaking. Like you have sickle cell disease, thalassemia. See, here you see most common infections in our country we see is like malaria. Where there can be decreased production will be there. So malaria and bone marrow suppression is because of the Epstein-Barr virus, parvovirus, your HIV, CMV infection, TB, and MAC, mycoplasma avium complex, then histoplasma, Kala Azar. So these are the infections. Sometimes we see that the child production only stopped, that bone marrow is not producing it. drugs, as all you have said rightly, is zidovudine. Another drug which we commonly use in our ART center is a Cotram, CPT therapy we give, no? So even cotrimoxazole. Sometimes these children have that fungal infections also, and we start off with amphotericin. So these are where we can see that, array, these drugs are causing anemia in the child. So we need to stop, or we have to shift to some other drug. Huh? Sometimes children may have malignancies like Hodgkin's and NHL. So there also there will be decreased production. Where it will be increased loss, or the RBCs are getting lysed faster, is in your uh, hemolytic anemias, as I rightly told you, that it can be thalassemia where the breakdown is there because of the hemoglobin. Yes, anything? Any question? Hello? The unmuting is the unmuting option is given for you not to talk amongst yourself. You have to answer my questions. Kindly mute yourself. Mute yourselves. So the losses can be through the GIT, as I said. There can be infections due to parasitic infections, like you have worm infestation. You can have dysentery because of the amoebiasis. It can be because of giardiasis. It can be because of Shigella infection. Then most common which we see is CMV infections, Candida infections. These all can cause blood loss. Okay. As you rightly said, we have an anorexia, poor school performances, child may be looking pale. And sometimes in the history, we have to find out what can be the cause. So we need to find out, is there a bleeding from any side? The child might be having, the young adolescent girl comes to you with menorrhagia. So she's losing lot of blood through menses. Or the child may be having chronic diarrhea, child has jaundice, drug history, as we said, or the child may be needing a repeated transfusion because of this anemia. Past history also we have to find out whether the child has any liver disease, any renal disease, or chronic infections like tuberculosis. Okay. Family history of anemia can also be there. Yes, which need transfusion. Bleeding disorders are there. Child is hemophilic, child is having thalassemias, recurrent jaundice is there, gallstone is there. That is suggesting of a hemolytic anemia like sickle cell disease or thalassemia. So in the diet history, what we will ask, we will see, because what is a diet? The child is not eating non-vegetarian. Sometimes they may land up with B12 deficiencies. Or the child is not taking the green leafy vegetables, or jaggery in the food. So iron deficiency is very, very common. So we need to find, and we all think.
Hello.
Ma'am, is it okay if we take up questions at the end of the session?
Okay, madam. Thank you.
Yeah, thank you. Preethi ma'am, please continue.
Yeah. So we can see the type of milk which the child is taking. Okay, no? Complementary. Sometimes what happens, why it is important to know the type of milk. Suppose the child is taking cow milk, they may have cow milk protein allergy, and then they may have to the diarrhea, and that may lead to some amount of blood losing, and that can also lead to anemia in these children. Okay. So when it comes to examination, we have to do a head-to-toe examination of the child to see for the signs of anemia. As you rightly said, that we have to check the palm, the child's palm, and see how severe is the. If it looks totally white, it is severe anemia. Okay, but at the corners, in the thinner and the thinner and the hypothinner prominences, if there are some pinkish islands and the center is pale, it is called as some pallor. And it is all red, it is, or red and pink, it is no anemia. Okay, so severe anemia is where it is totally white. Sometimes we have to see there is a hemolytic anemia, jaundice will be present because the cells are hemolyzed, and that leads to jaundice. So you have to check for the jaundice in the eyes. And the child, because of severe anemia, may have tachypnea, tachycardia, congestive cardiac failure, and there can be hepatomegaly. Child may have lymphadenopathy, child may have petechial rashes, and For that, we have to see whether the child is landing up with any type of malignancy. When you start to open the mouth, you see that there can be glossitis, angular cheilitis is there, angular stomatitis is there, candidal patch can be there, and child can have platinikia, cholionicia. These are all signs of vitamin B deficiency, B12 deficiencies, as well as iron deficiencies. So this clinical and history wise, you have come to know that this child has anemia. Any investigations you want to do? Yes. What are all the investigations? We want to check the hemoglobin levels first though. Is it not so? So let us see the hemoglobin levels, which will suggest to us as the child has anemia. When we do the smear, what we will see, if there is a microcytic anemia, it's an iron deficiency or thalassemia. Macrocytic means large cell. Okay. So bigger cell suggests B12 deficiency or folic acid. But the child has a normal cell. The cell size is neither small or nor big. It's normal. So that suggests anemia of chronic infection. Then you can see the platelet count. When you see the platelets, if they are less, pancytopenia means pancytopenia means all the three cell lines are decreased. Okay. Like we have a aplastic anemia because of Epstein-Barr virus or parvovirus, which we saw na infection. It may not only cause only anemia, but it will cause or bone and bone marrow is not working. All the three cell lines will not work. No. So there will be the platelet counts also will come down, WBC will come down, RBC count also will come down. Okay. So we see in aplastic anemias or lymphoreticular malignancies. So next investigation, what we can do is we check for the retic count. Retic count, if reticulocyte count is increased, that means hemolysis is going on. That is mostly commonly seen in the hemolytic anemias. But if it is low, that means that your marrow is only not working. Marrow is not producing the cells. Okay. So what we have to do, how do we manage this anemia? First you see that these children need to be dewormed. As I said already, the worm infestation itself is a very important cause of anemia. So first you deworm these children. How will you do that? You have to give albendazole. How much you will give? See, children up to 2 years, you will give 200 mg of albendazole, and above 2 years, you will give 400 mg. But this is only a single dose you will give. Okay. Then you will start on with iron therapy. Now iron therapy, how you will give? The dose is between 3 to 6 mg. Okay. And this iron is best absorbed when the child is empty stomach. So in between the 2 meals you can give. And then and how long you should continue? You should continue almost up to 3 months, because initially within 1 week when you give the iron, the child's malaise comes down, irritability comes down, easy fatigability comes down, retic count improves, and all those things will be okay. But why we want to continue for 3 months is iron stores also have to be replenished. So we will continue till 3 months. Okay, na? Then we have to give folic acid also. How much? 100 to 200 micrograms per day we should give. This will prevent the folic acid deficiency. But we have to, obviously, when you are treating all these things, we need to tell the mother about the diet also. So iron-rich foods we should know: green leafy vegetables, peanuts, jaggery. We should tell them about that bellam chikki patti, or we call it a chikki. Good moongfali chikki. And some eggs, chicken, milk. These are poor sources. You will think that you are telling them that to take lot of milk, lot of eggs, chicken. They are rich of protein, but they may not have good. They are poor sources of iron. Good sources are only green leafy vegetables, jaggery, red meat, or dates. Such things you should advise them. Okay, so when the child is seen to have severe anemia, or child is in failure, and megaloblastic anemia is there, child is having bleeding, child has pancytopenia, you think that it can be malignancy, and child is not responding to your iron therapy, which you have started as 3 to 6 mg per kg, and you will give when in an empty stomach in between the meals. So if you are doing all these things and the child's hemoglobin is still not improving, then you are definitely going to refer this child to a higher center. Okay, till here anemia is okay. Then we will see about thrombocytopenia. Thrombocytopenia, how do we define it? Platelet counts are less than. Anybody? Platelet count less than? All are sleeping, are Platelet count less than 1 lakh. It is written so very clearly. Okay. So it can be as simple as a manifestation of HIV infection also. So direct initially infection will lead to thrombocytopenia. Okay. So it can be because of water conditions. It can be because of immune mediated platelet destruction. It can be thrombotic thrombocytopenic purpura, or as we said that bone marrow is only not functioning and there is no production of the platelets. Okay. So what we have to do? We have to do the bone marrow to see how it is functioning, and how to manage thrombocytopenia is if the counts are less, we will give the platelet-rich plasma or we'll give platelet transfusion. Okay. But once you have diagnosed malignancy or aplastic anemias and all those things, so what will happen? If that is ruled out, we have ruled out all the malignancies and other causes of thrombocytopenia, you need to continue with your ART and it may respond. Okay. Thrombocytopenias have to be referred to the children specialist. Okay. So anemia thrombocytopenia is one complication which the CLHIV children can have, and we just read how to identify that and how to treat it. Okay. Now next thing we will go for this thing is a hepatic dysfunction. This can be there because of what all we said. It can be because of the understand that HIV itself can cause a liver dysfunction. So there will be alteration of the liver function. Hepatomegaly will be there. Child may present with jaundice. So this is a very common thing. Okay, hepatomegaly will be there, raised enzymes will be there. It may be chronic or a progressive liver disease, and causes can be because of hepatitis A infection, E infection, D infection. It can be part of the co-infection. Drug toxicity, as we rightly said in the starting only, all our ART drugs also can cause a liver toxicity. Okay, and child can have fatty liver all because of malnutrition. So how will it manifest? It manifests as jaundice. The child may have nausea, vomiting, not eating, whatever the child is eating, his child is throwing out, and child may have high grade fever. When it is cholestatic jaundice or conjugated bilirubinemia will be there, the child will have itching and child goes on scratching, pruritus, with which the child can come. And when there is a cholestatic jaundice, child may have something called as pale stools. Instead of yellow colored stools, they may have pass white color stools. And the jaundice will be deep, urine passage will be dark urine, the patients will tell. So when you will examine, you will see that the child is icterus. You will see in the eyes the child is having jaundice in the bulbar conjunctiva sclera. You will see there is jaundice. Then you will see that the child's liver is palpable. Child may be irritable. Child may have excessive sleepiness. Child will not eat. Even if he is eating, he may throw out. And the child's abdomen starts to get distended. There might be ascites and bleeding manifestation might be there. So child may have epistaxis. Sometimes child might be vomiting. Blood also come in that. Vomiting, hematemesis might be there. They may have melena. So this might be the presentations. So what we should do? We should do the liver function test to see what is the level of bilirubin. You have to see how are the enzymes, ALT, ASTs, how they are. Many times they will be elevated, and you will see, check for the infections. We will see malaria, send us a smear for malaria, where you can see that the jaundice is there, anemia is there. That can be because of infections like malaria. Then we have to do the virology samples for HIV, the hepatitis A, hepatitis B, hepatitis C, to check for blood glucose, because hypoglycemias are very common when they have a liver disease. Then the liver's indirect functioning will be because of the prothrombin levels. So prothrombin levels you should you should see, APTT you should see, you would estimate, INRs you should see, and check for the electrolytes. Okay. So presence of jaundice is indicative of acute hepatitis, and you have to see the severity when encephalopathy or coagulopathy is there. So encephalopathy, we saw that the child may have altered sleepy pattern, child becomes irritable, child will not eat. And coagulopathy means the child starts to bleed from different sides. Child may have anemia, thrombocytopenia, and child may vomit blood, hematemesis will be there, epistaxis will be there, melena is there, frank hematochezia can also be there. Okay. So how do we treat? So what is the offending agent? Sometimes if the drugs are there, then definitely we stop the drug. If the child is on ATT, most common thing is that, as we said, the child is having ART also and ATT also. So you should stop the ATT, check for that, and when the enzymes are raised, you need to hold on and then again restart it. Okay. Then we have to monitor, give the child bed rest, give fluids, manage his nutrition. And when there is a hepatic failure, we have to give vitamin K, we have to give fresh frozen plasmas. If need be, we have to give the electrolytes, check for the sodium, potassium, and give that. If the child is bleeding, we have to give H2 blockers. Child may be admitted in the ward, and low protein is mentioned because they can land up in the encephalopathy. Is it not so? So you need to know the presence of hepatitis and its severity, etiology will definitely affect the initiation of the drug regimens and ARV, especially nevirapine. So that also causes hepatotoxicity. So we have to hold on few of the drugs for the babies. Other infection which we can see is respiratory comorbidities. So this respiratory means they can be pneumonia, or the child can have bronchiectasis. So bronchiectasis ante enti, there is a disease where we have a irreversible abnormal dilatation of the bronchial tree. Okay, so bronchiectasis is classified as WHO stage 3. How many you have answered rightly? You all mentioned stage 3. This was a question of pretest law. Yes, you wrote. So here you understand that bronchiectasis is a WHO stage 3 disease. How does it present? The child may have fever and child has persistent cough. The child will go on coughing, and when sometimes the sputum also will come. So purulent sputum will be there. Child might be coughing blood also, and that should be the clue for you that the child has a chronic lung disease, suppurative lung disease. It's a bronchiectasis, and the presentation on general examination will be clubbing will be seen. And when you ask her that, you will see that the child has a crepitations here and there. Okay. And they usually don't so easily resolve with routine antibiotics. And see, X-ray chest will be showing cystic spaces. Honeycombing is a classical pattern which we see on X-rays in bronchiectasis. So how do you manage? First of all, though, you have to admit this child and you have to posteriorly drain the sputum. If need be, you have to give oxygen. You have to start off high broad spectrum antibiotics. And if possible, if there is a chance, we can always do the bronchoscopy, give a bronchial lavage, and the sputum culture can be done. The lavage culture should be done, and appropriate antibiotics should be given. The bronchial infection is there, that is causing a this thing. So we have to give bronchodilators along with the positioning of the baby, because postural drainage of the sputum has to be done. And sometimes the lobes are so much inward that child is not able to manage it. Sometimes we need a lobectomy also should be done, or sometimes the infection is so much, or they may have complications like empyema and all those things. We need to put a ICD also. Okay, so lobectomy also should be done. The next infection, what they said was lymphocytic interstitial pneumonia, that is called as LIP. Okay, so this is also stage 3. Stage 3 clinical condition is a lymphoproliferative disease, but this is a non-infectious disease. But remember one thing, that it can be coincidentally present along with your bronchiectasis also. So at the time the child may have bronchiectasis, at a time the child may have LIP also. This is very, very common in HIV children. So what happens, why it is there? Because there is an infiltration of the CD4 lymphocytes and histiocytes, plasma cells are there. These are present in the alveolar septa. Okay. So this is commonly seen in children more than 2 to 3 years, and sudden onset cough will be there. The child will be having lot of dyspnea. And this is associated with being, and the child will be having an exertion dyspnea. Child will not be responding so easily to your antibiotic or anti-TB drugs. So LIP treatment is what? It needs a bronchodilator and a course of steroid. Okay, short course of steroid should be given. So remember that when you are evaluate an HIV child with respiratory symptoms, you should remember that one or more things also will be there. That is what I was saying. The child may have cough, child may have breathlessness, child associated TB is there, bronchiectasis is there. At the same time, the child may have lymphocytic interstitial pneumonias also, all in one. So this is briefly about respiratory problems. You saw anemia, you saw thrombocytopenia, you saw bronchiectasis, you saw lymphointerstitial pneumonias, and now we will see some of the other conditions which the child presents. It's a neurological problems with which the child oftenly comes to you. So HIV enters the brain through infected monocytes and T lymphocytes. It crosses the blood-brain barrier and direct invasion of the nerves. The virus directly attacks the nerves, which causes inflammation. Then it can cause degeneration and disruption of the neurotransmission. So the demyelination occurs and vasculopathy will occur. So what will happen in these children? This changes causes immature brain to become, it will be compromised. So child may have HIV encephalopathy. That is what we call it. Okay. So risk factor for neurological involvement. Why it is direct infection will have more risk, the more morbid mortality will be there, more morbidity will be there. So perinatally, if it is transmitted, then it is definitely very, very high chance of neurological comorbidities in the children. When the child is immunosuppressed, then also the viral load is more. It will cross the blood-brain barrier and cause more infection. Third is the age of the child, definitely. The younger the age, the more is the CNS infection. Okay. So highest is when in the first 2 years of life. Okay. When the rate is almost 9.9. But in the second year, it is 4.2. And in the third year or beyond that, it is only 1%. So in the first year, first 2 years, you remember almost 10, then 5, and then 1. Okay. But if the child is born low birth weight, if the child is a preterm baby, child is not having enough feeds, then all the more this chance increases. So the smaller the baby, the risk is much more. Okay. So HIV associated encephalopathy, we already saw that the child's neurocognition will be affected. The child may, from neurocognitive distinct to severe dementia. So asymptomatic, all the spectrum. The child may be not symptomatic at all to the dementia. Child forgets everything, cognition will be lost, child may not be able to do the normal functions. Okay. And the child may, because of vasculopathy, may have stroke syndromes, like the child may have paralysis, hemiplegias. Okay. So general principles of management of neurological morbidity, what we should do, it will be a subtle presentation and you have to look for the children, what are the symptoms. So syndromic approach is very, very important to identify what can be the etiology. We should do the scanning, like you should do an MRI scan or CT scan, and systemic, all the systematic evaluation should be done, and we should start the ART in the right time. And we should see to it that the viral loads are suppressed, so that they definitely the CNS insult will reduce. If you have seen the mother, antenatal mother, we have to see that the virally suppressed she should be, so that perinatal transmission is less. Okay. So this will prevent her neurological morbidities and mortality in the baby. Okay. How does it present in the child? Yes, the child may have, the normal child up to 5 years, the child should be sitting at a particular age, the child should be standing, child should be walking. So that will all be delayed. The language will be delayed, and child may have something called as a small head, that is a microcephaly. Child may have present with spastic CP, that the spasticity will be there, very tightening of the body will be there. And when tracts are involved, the child may have seizures, child may have ataxia, child may have involuntary movement, that is what the basal ganglia, but that basal ganglia affection is less. It directly affects the cortex more. In the older children, what will be there? The child is not able to talk properly, converse properly, child will not be able to perceive, motor activity is affected, attention span is reduced, child will not be able, whatever the child has learnt also, child starts to forget. That is a regression or slow progression, will not be able to progress further. Or నేర్చుకున్నది మర్చిపోతాడు, రానే రాదు, వచ్చిందే మర్చిపోతా ఉంటారు, or పోతా ఉంటాయి. That the milestones which you have achieved. Put child is, say suppose the child is walking, the child starts to regret and regress and not able to walk. Child starts to only sit with support or stand with support. So that is what is a regression. Slow progression is child has not achieved that at all. Okay. So HIV encephalopathy is the most common CNS manifestation which we see in our HIV pediatric age, and it can occur in first few months of life. Okay. And this is a sign, it may be the immunodeficiency. Sign of severe immunodeficiency is how the child may present with meningitis, child may not develop properly, developmental milestones are delayed, intellectual milestones are delayed. So these are very, very important things. You should see that failure to attend or loss of the attend milestones, or the progressive impaired growth monitoring, where it you see the head circumference, the microcephaly, as I said, if the head circumference is smaller, then you have to be very, very alert that this something is going wrong. The child is landing up with encephalopathy. So motor deficits are there, child has paralysis, or when you are testing with the knee reflexes are very exaggerated, or the child tends to have ataxia, or the movement disorders are there, child is unable to walk, then this is definitely a sign of HIV encephalopathy. Okay. How should you monitor? In every visit you have to examine these babies. Okay. And you have to see any signs are there, you have to pick up early for the development. When you are seeing the height, weight, we have seen now. So what is the development of the child? Is the child going to the school? Is the child attending the classes? Is he concentrating properly? Is he behaving properly? All this has to be asked and inquired. It's very, very important to find out. So how do you investigate? You have to, as I already said, you have to do CT scan and MRI, and the cognition will be affected. It's the same thing. But most important for us in our center, when the child comes, not only the weight, height, mid-arm circumference you are checking, or the routine CBPs you are doing, you have to see for whether the child is walking normally, appropriate for her age, or the developmental delay is there. It's very, very important. I'm again and again putting the same point. Okay. So these children should go routine assessment, and you have to evaluate the child for the developmental delay and scholastic performance, behavioral problems are there, and appropriately refer the child to the pediatrician or the higher center, right? So what are all the other comorbidities the child can have? The child can have cardiovascular manifestations. Okay. So sometimes they may have multi-factorial origin, it can be there. And sometimes due to the nutrition deficiencies, they may have dilated cardiomyopathy as a very common thing. Okay. DCM we call it. So a dilated heart will get dilated. It can be because of many nutritional deficiencies also, drug also like zidovudine. Okay. So very common complication of zidovudine. Okay, so we have to monitor very closely. Sometimes these children have early atherosclerosis, new emerging disease. Atherosclerosis is because of what? Increase in the fat, which we see most commonly in the plaque formation. Most commonly we see in the adults, but even in children we need to be focused that it can occur. Now pulmonary artery hypertension means what? The pulmonary arterial hypertension occurs because of the pulmonary vascular resistance or the pressure, right ventricular pressure, okay, that is affecting the child, and this will cause what? The child will present with breathlessness. So breathlessness, if it is there, then what is there? There can be a possibility that the child is having a failure because of, right from your anemia, you should remember, from there, or respiratory problem or cardiac problem. Now, what is this cardiac problem? It can be a pulmonary arterial hypertension. When you say, when the resting mean arterial pressure is greater than 25 mm of Hg, or MAP is of after exercise is 30. Okay. So how will it present? It may have distress. It may be as a failure. Also tachypnea, tachycardia, chest pain, arrhythmias, all this can be a presentation of your pulmonary arterial hypertension, right? So these are few things we should know, that in a child when they come, they may have, most common is malnutrition, but along with that, you should see the respiratory complication, cardiac complication, most important neurological complication. You should see a child having a gastrointestinal complication like a jaundice presentation. So all this you have to evaluate the child properly, right? Okay. So here in pulmonary arterial hypertension, you'll see X-rays, you get a ECG, where it will be a right axis deviation, right ventricular hypertrophy will be there. So cardiomegaly picture definitely untadi. Okay. So all other causes are ruled out, then you should think that it can be because of HIV only. Most commonly zidovudine can cause it. Okay. Thank you so much. And you have to attend the post test, I think. Is it not so, Shweta?
Ma'am, the pre and post will be circulated. I mean, the pre has been circulated. The post will be circulated later. For now, once we take up the questions and then we'll have the feedback poll, ma'am.
Okay, okay. Any questions? Are the quick questions because I have some other meeting to attend to in the.
Okay, okay. Requesting all the participants to please email your questions to us and we'll forward it to ma'am and then forward the answers back to you. Ma'am, thank you so much for facilitating this session. We won't keep you waiting. Can we quickly run the feedback poll, please?
I hope that you understood this session, and this was very important session because you come across pediatric HIV cases. So many CLHIVs are there, and these are when you see as a general physician or non-pediatricians, I should say that you get rather skeptical when it comes to a child. So you should not worry that the child has walked to your center. So from head to toe examination, you should do see for the anemia, see for the pallor, see for any jaundice is there, liver problem is there, respiratory distress is there, or cardiomegaly. So all these things you should see where at your center, if you can manage, definitely you should manage, like your malnutrition. You can talk on the nutrition, counsel the mother, talk to them, and the drugs which can harm the child causing jaundice and all those things, we need to hold on that. So it's very important that we understand this, we learn it. These sessions are very, very important for you to understand, read, go through that again. Any questions are there, please post so that we are there to answer you. It is very, very important session. You should understand that CLHIV, because we have to test and treat. And what is the new slogan which we have under the NASA? Anybody? End it, like we have end TB, like that. We have anything for the HIV? When should we control the HIV or treat the HIV, eliminate the or eradicate HIV? Anything is there? The slogan is there? Anybody in the audience? New guidelines, national guidelines say so? We don't say anything. Let that HIV continue like that only. Huh? Yes, anybody? Nobody wants to answer. Eh? What have they answered? Let me see in the chat.
We have one in the chat box, ma'am. End by 2030.
Good. So Piyush of Attack needs a good applause. Yes. You have to end. So if you have to end it, you have to understand how it CLHIV patients present, what can be complication and how to manage and treat. And likewise, at least when you know what can be managed at your center and when you have to refer to the pediatrician or to the higher centers. You need to know about the drugs which can cause complications. You need to know from your this thing, what all in your center we can support the child with. Okay.
Thank you so much for your kind words, ma'am. Thank you to all the participants for patient listening. Ma'am, can we conclude the session now?
True. Okay. Thank you.
Thank you.
Hope it was a helpful session for all of you. And
yes, ma'am.
Thank you so much. Thank you, Shweta.
Thank you, ma'am.
Okay. Any questions? Are the quick questions? You can just.
I'll email them to you, ma'am.
Sure, sure, sure.
Right? Okay. Thank you.
Okay. Thank you so much.